and welcome back to Money Power Health, a podcast on how health is influenced by wealth and power. As we discussed in our introductory episode with Sandro Galea, one of the main things that determines our health is the distribution of resources and opportunity, of money and power. Yet when we think of data on health that might better inform decisions in the future, often we're thinking about healthcare related data, about patients, disease prevalence, or risk factor epidemiology. This week, I wanted to speak with someone who's trying to help decision makers think more broadly and more upstream when it comes to data on health. As you'll see, my guest this week has already been at the heart of some very interesting work on inequalities in health, on who we think of and what voices we might include. Her own personal story is a testament to her tenacity, intelligence, and commitment to studying the causes and practical solutions to within and between country inequalities. Earlier in her career, she was heavily engaged in advocacy efforts to incorporate the voices of young people in setting the global public health agenda. She was the Secretary General of the International Federation of Medical Students Associations in 2013-2014. She was a Moremi Fellow for Young Women Leadership in Africa in 2012. And she was named an Emerging Voice in Global Health in 2018. This week, I'm speaking to Dr. Salma Abdalla about going upstream when it comes to data and decision making. Salma is a Sudanese medical doctor who studies how data on the social, economic, and commercial determinants can be used to inform decision making on health and health equity in different contexts. She was the director of the 3D Commission on Determinants, Data Science and Decision Making, and has also served as a secretariat member for the WHO's Independent Panel for Pandemic Preparedness and Response during the COVID-19 pandemic. Dr. Abdalla, hello and welcome to the podcast.
Hey Nathan, how are you?
I'm not bad. Thanks so much for joining me. I'm really excited to speak to you. We've got a lot to dig into, and yeah, I'm super excited to talk to you about your ongoing work on the wider forces that shape health, how they might better inform decision-making, some of your other scholarship around global health. But I wanted to first understand, because you've been quite dynamic, both in your research and in your activism before that, on what got you interested in global health and health inequalities, and what about that experience shaped how you approach what you do now?
That's a big question. Well, I would say maybe a good way to think about this, for me at least, was that I just was going through medical school in Sudan. I think two incidents come to mind. Just having a lot of young patients who come in with complications from female genital mutilation, FGM, or during my pediatric rotation as well. We would have a child that comes with malnutrition. We would treat them in the hospital. I had a great supervisor, and then she would say, just watch, they will come back again in 3 months. And that would be exactly what happens. That child would come back in 3 months, and we would have to treat them again, and they will go out to the world. And I think to me, it just felt like there must be a better way to make sure that we address all the issues that make people sick, that would get them to the hospital. Maybe is there a way to actually deal with a lot of the health issues that we find in the hospital outside of the hospital? And that just got me interested in something beyond the healthcare system. It just felt like I could just be in the hospital 24/7, fixing or hoping to fix everyone I can, and then that would not really make a dent in what's happening in Sudan. And because of that, I just got really interested in health inequities. I saw people in my neighborhood who would get sick because they just didn't have enough money to actually eat healthy. And all of that, again, got me interested not just in addressing all the policies before getting to the healthcare system, but really, what are the health inequities? Why do we see more sick people from my neighborhood compared to the neighborhoods of my other friends who live in more affluent neighborhoods? So that got me interested in health inequities. And at that time, I really didn't know there's something that's called global health. I just thought you just deal with health and health inequities at the local level. But then I had other opportunities. I think we'll talk about those later, where I got to the World Health Organization in Geneva, and I realized there's this field that's called global health. And to my mind, again, maybe it was naive, I thought that meant you just care about the health of everyone, everywhere, especially people who are disadvantaged everywhere. And I guess that's where all this started.
Wow, fascinating. Well, this is great, because this is exactly the question I wanted to ask you. I too was not always sure what global health meant. And I naively thought it just meant the health of everyone everywhere, and sort of conceiving of the earth as a single country and everyone having the same right to health, and then going about seeing the obstacles to that and possible solutions to that. But having become a little bit more involved in the last couple of years, I've realized that that is a naive, perhaps, assumption compared to what public health, what global health is in practice. So I thought I might ask you that, since you did make that transition. How would you define global health, and what are the differences between that sort of naive or very broad definition and what it is in practice?
Yes, I think that's a great distinction that you're making there, because we did some analysis a few years ago, just looking at what are definitions of global health, particularly global health scholarship, because as I was thinking about getting into the field more, I thought, before I become committed to this field, maybe I need to understand what is it about. And so we did that analysis, and there are a lot of definitions of global health. To be completely honest, they're not well aligned. It seems to me that overall they revolved around the idea of health of the global population. So those are the definitions that people are comfortable with. There's one definition that was developed by Copland and colleagues in 2009 that I think a lot of people really refer to when they write about global health, which tried to identify global health as a field for both study, research, as well as practice that just prioritizes improving health as well as achieving health equity for people everywhere. And I think that's the one I really loved, and that's the definition that got me interested in the field. But then when you look further, you see a lot of definitions that focus on healthcare, definitions that focus on geographical areas. So this is the general definition of global health as a field. In practice, and that was the second part of the paper that we did, we looked into 25 global health journals over the past 20 years to see what is published in those journals. And in practice, global health is really about publishing in conditions and diseases that are focused in low and middle income countries, not necessarily with a focus on forces that are not biomedical. So most of the research in global health focuses on, which again is needed, but not necessarily would address all the issues we face when we talk about the health of the population. So a lot of the research focuses on the health system, it focuses on infectious diseases, it focuses on maternal mortality, but even within those topics, it really focuses on the biomedical component. How do we get people to the healthcare center? Instead of thinking, why do we get a lot of maternal mortality? What are the issues that faces a woman who's having issues in delivery? If the road is not working, if she cannot have transportation to the healthcare system, are really fixing something by just addressing the need for a healthcare system. So I think this is where the struggle is right now in global health, both moving away for some of the biomedical focus, but also understanding that global health should really focus on the global population and inequities everywhere, and instead of just focusing on low and middle income countries.
Yeah, definitely. I mean, I'm just digesting what you're saying. I read that paper and found it really, really compelling. And we spoke in a previous episode about meta-knowledge analyses with Lisa Barrow. And it's another example of those, like really taking a bird's eye view of the whole field and then seeing the biases and the trends in that field and how different the empiric research is compared to the definitions of that research area. And this was, I thought, a really fascinating example to me of this and what global health scholarship often is in practice. And I guess linked to that and this broader idea, which you're implying that part of what global health maybe is or should focus increasingly on is equity in the conditions that generate health, in the sort of social determinants of health. Why do you think that is the way global health scholarship is in practice over that time period? What do you think those results reflect?
I mean, not to be too harsh on the field of global health, I think this is something most of, if not all of public health research suffers from. I think it is, I mean, I can psychoanalyze a lot of the people who do research in the field, but as someone who focuses on structures, I revert back to the structures that create such an incentive to always focus on the biomedical component of research. And I do think focusing on social determinants of health would require first expanding the methods that we use in understanding disease and how we link policies or interventions in a field that is not healthcare related to health outcomes, and that would just require a lot of resources that we do not have. But I also think, just maybe going back to global health, doing biomedical interventions is a great way to show concrete outcomes. I can go outside today and say, I would like to address the issues with malaria. At the end of the year, I can report back saying I bought 50,000 mosquito nets and distributed those. It is extremely difficult to say we want to conduct research to see if we incentivize policymakers to address all the water system in the city that helped reduce malaria infections by this percentage. A, that would take a long time. B, it would be very difficult to actually assert causality. And if you're working in a system where the structures for getting more money and more funding is dependent on showing results, I would revert as a researcher to do something that I can actually quantify. So I think that is mainly the issue, at least to me, in conducting research, not just in global health, but in public health in general.
You're right. It's sort of, it's not that you're casting aspersions on the intentions or the beliefs of those who are doing that research, but rather it's you're taking that bird's eye view and seeing there are structural factors that bias towards certain types of study design, certain types of disease focus. Obviously, funders play a role in what they prioritize. That makes a lot of sense. But it strikes me, if I might push you a little bit, it strikes me that it isn't just a question of I guess, global health field, because you've also done some really interesting work surveying what people think is most important to health, and through the work that you've done with the 3D Commission. So I was just wondering if you might, first of all, tell us a little bit about the 3D Commission, which is where you and I first met, and then speak to some of the results of these surveys that you've done that sought to ask people what they think the most important determinants of health are.
Sure. I think that, to be completely honest, both the 3D Commission and the survey that we did were just illuminating to me in a sense that I always thought, as we discuss now, that we just need to provide more focus on social determinants of health and research. But then it realized, even if we do that, even if all the research in global health and in public health in general is focused on the social determinants of health without addressing issues beyond scholarship, we're not really going to improve the health of populations, and particularly improving or addressing health inequities. So the 3D Commission was an initiative that was created both by Rockefeller Foundation and Boston University. We started in 2019, and I had the honor of being the lead project director for the 3D Commission, mostly looking at the research component of the work. And what we really wanted to do was embrace this increasing focus on social determinants of health that was really driven by the World Health Organization 2008 Commission on Social Determinants of Health, led by Sir Michael Marmot. But then the 2 decades after that, we were seeing more and more scholarship on the topic, coupled by the increasing availability as well as complexity of data that we're seeing, often labeled as big data. And the question we put for the 3D commissioners, which composed with, and I'm really proud of this, a diverse set of experts from across the globe, not just geographically and in terms of gender identity, but also in terms of the expertise. I feel like we got the best of all worlds in the 3D Commission, which took a while, and we can actually talk about what it takes to create diversity in a commission later in this podcast, if helpful. But we wanted to bring commissioners to discuss how can we use big data on the social determinants of health and the momentum in social determinants of health to inform decision making. So what would that take? What exists out there, and what type of recommendations can we provide to policymakers so we can make that change happen? And part of that work that we did was conduct a survey in 8 countries that were also geographically diverse. You can look into some of those results in our 3D Commission, but it really ranged from countries like China, India, Indonesia, Egypt, all the way to Germany and the United States. And what we found was that overwhelmingly, lay people or the public, when you ask them what matters for your health, they say healthcare. So it's not just an issue of research on social determinants of health, it is also an issue of what the general thinks matters for their health. And if people think healthcare matters most for their health, that means they will probably, if they're capable, will not be advocating for other types of policies. And at the same time, we actually found that people ranked politics as the least important determinants of their health. And if you ask me, of course, I think politics is one of the most important determinants because it, in a way, it actually shapes all the other determinants of health. So that was the main finding we found from that study. And looking at the literature as we wrote up that study, it was actually very helpful to me to see that maybe part of that issue was that research on the social determinants of health and communication about the social determinants of health is rarely focused on working with the public, educating the public, reaching communities. Even when it's done, it's mostly focused on either reaching other researchers or reaching policymakers. And that is something that we need to work on changing.
Wow. No, absolutely. And I've really been digging into a bit more of this literature on both how to frame health and the wider determinants. There's some work that's been done by the Health Foundation here in the UK on finding ways to do this more effectively and gauging what the response from the public is. And then also thinking about who else contributes to those definitions, like what other factors maybe shape or even pollute understanding about what really drives health. But I think that's really fascinating. And your point about politics is so important. As something Sandro Galea alluded to in the first episode of the podcast, that people tend to think of politics as being, not that relevant to health, but it shapes so many things. And that's not independent of whatever geographic context you're in. Politics shapes health in a huge number of ways, including conflict, right? Including geopolitical tensions and trade and all these kind of things. It's super fascinating, Salma. And I guess just to pick up on what you alluded to, you mentioned that a lot of work goes into creating a truly diverse group of thinkers, group of commissioners, like you had on the 3D Commission. And this is something that's increasingly discussed, across organizations, within countries and between countries. Like, how do you ensure the best possible representation, the most diverse set of perspectives, but also individuals? What are your reflections on managing that, being the director of that process?
I think in one word or maybe one sentence, it's really hard. You have to be committed to true diversity. And I say this, and particularly recently, I think one important component of diversity is diversity of thought. So I think this is something that we really aimed at getting at with the 3D Commission. But I thought, and maybe again naively, because I've seen a lot of work out there, that it would be easy to put together our commissioner list. But then that actually took a lot of work. It took a lot of months. And I think the main issue that we faced was that there are a lot of really prominent and helpful and thoughtful people out there. And because those people have already done a lot of work, it's usually very easy when you ask for recommendations for people to just send you back to the same list of experts that you see every time. And if you don't want just the same list of experts who are most of the time are in high-income countries, even if they're from low-income countries, they're often people who are situated in high-income countries. If you don't want the same list of people, you have to be willing to sit there to look at, I don't want to say obscure because they're not obscure in their local context, but entities or items that would not be highlighted globally, to be able to find experts who are very attuned to their local context. And that took time. So we were just, from the beginning, we were committed to doing that. We were committed to having a diverse set of experts, both in terms of thoughts and geography and gender. And it took a long time to do it. And I think that would just be my suggestion for people in the future. If you really want to do something like that, you should be willing to put in the work and know that it will not come easy.
Yeah, absolutely. I mean, it's such an interesting reflection from someone who's actually tried to go out there into the world and look beyond, I guess, the common names or the most obvious repeat offenders when it comes to commissions. And I think that's that can be a difficult part of the job. And I guess part of that is also you have to invite people to do something that they maybe haven't done before, or to invest a bit of time in finding out more about it, or putting themselves in situations that initially might be uncomfortable compared to what they're used to, right? In terms of working with new groups of people, like you said, bringing together people with diverse perspectives, all these kind of things. But what an interesting reflection on the challenge, but also, I guess, the promise of doing that kind of work in terms of the breadth of the commission you end up with and the voices that you end up elevating that are maybe new and different and contribute a lot. That's really, really fascinating. I'm just thinking about your experience of having worked with such a wide range of people, and thinking about some of your other experiences doing consulting work, and in particular thinking of your work on the Secretariat for the Independent Panel on Pandemic Preparedness and Response. I think that's the full title. I mean, again, another group of people tasked with a really ambitious goal, and you had to work with people at different levels of seniority, different disciplinary perspectives. What are your reflections on that process, just as much as you can share, obviously, that you think might be relevant to others who find themselves in similar positions?
So I would say I can't, you're absolutely correct. I cannot share much on that. I think maybe one thing I would say is that it was really helpful as an early career scholar and maybe global health advocate to be part of such process, because in a way, and I'm not saying this in a disparaging way, but it was really helpful to see that everyone at every level, they're really trying to figure out what to do as they're moving ahead. There aren't a lot of people who are certain, and I think that's actually a positive in that process. There are not a lot of people who are certain of the right answer at the right time. There are a lot of people who care about improving the health of the global population, who were put together in a situation where there was a lot of uncertainty, and what they wanted to do was work together, listen to different perspectives, and actually get to an answer that might be as close to the truth as possible. And to be completely honest, that was just really refreshing to see, because you always think, I think as a doctoral student, as a young doctor, you think one day I will reach a level where I will know the answer and I will be certain about what needs to be done. And it's helpful to just see that no, it's an evolving process. It might get more complex over time. You would draw on more experience and knowledge, but you are never truly sure of the right answer. You just have to be driven by science and your values to try to reach as close to the truth as possible in your to get to as close as possible to the truth in your answer, and hope that and I think this is another thing I learned, there are always going to be negative consequences and trade-offs, and hope that you don't really cause a lot of negative consequences. And that was really an important lesson for me to learn with the independent panel. I think at the same time, I would say if you're a young, early career researcher or an advocate, do not be afraid of voicing your opinions and your insights. I think they matter. You will feel like what I say might not be helpful, but it really is helpful. In a way, you will always bring a different perspective. And what I found was that in a lot of those spaces, those different perspectives would be appreciated. And when you speak up, you actually also go through the process of thinking out loud with others and improving your own thoughts process, which was, again, very helpful for me. So that would be my advice for an early career person if you find yourself in such a situation.
What a really interesting and quite positive reflection, Salma. You know, it strikes me that, and this is just my experience of speaking to students who are very active in advocacy and, you know, kind of just starting out, that they are really strong on values and sense of right and wrong, and are full of energy to correct those wrongs. But especially in the beginning, sometimes they haven't necessarily been exposed to lots of different opinions, people at different levels of seniority, more complex challenges, trade-offs involved sometimes in the implementation of policies, you know, these kind of the complexities, the nuances that naturally come through through conducting work in an area and through working with a variety of people, right? And it strikes me that at quite a young age and an early stage of your career, you've been thrust into some of these debates, either through your work as a medical student, being involved in these kind of high-level meetings, or through your work in consulting for the WHO, through being part of the 3D Commission, through being part of the independent panel. And thank you for sharing what you have shared. Do you think your perspective has changed over time? Like, either have you become more pragmatic in some ways, or almost more driven and adhering more closely to certain values? How do you think your perspective's changed over that time?
Oh, can I pick door three, which is I think I probably became more driven and more pragmatic at the same time. I don't know if that's possible, but it feels to me that's where I am right now, and that might change if we speak in the future. But I would say so. It's so funny. And I think also something that really was helpful with changing my thinking. I don't think my values have changed since I was a medical student in Sudan working with the malnourished child. I don't think that will ever change. I know what I would like to do and hopefully be part of changing the world to a better place where we improve the health of populations and definitely reduce health inequities. I think my ability to acknowledge that other views could actually equally be as helpful and as beneficial, I think grew over time, which I am very grateful for. At the same time, I think I realized that moralizing our goal might not necessarily be the right way to move forward. I think sometimes to reach our goal, to be able to help people, we need to understand that decisions are complex. There's almost always a trade-off. There's almost always some uncertainty. There are a few decisions in life where there is absolute certainty, and most of what we work on, especially when it comes to social science, is not certain. And because of that, we need to be able to work with people with different perspectives to reach our goal. Because sometimes it's better to actually advance the process further than just being right. And I think 10 years ago, I always just wanted to be right and show people why they're wrong about something. Not to go on a tangent here, but I think, and maybe that's not a good thing, but I was thinking one thing that really helped me think through this process that is not necessarily related to global health, but it was the revolution we had in Sudan. As a medical student, I was always not as many as my other colleagues, but I was on the street with protesting the government and the president that we had even before I was born. I've only known one president my entire life. And knowing all the horrible actions that were being done against the population and seeing them at the hospitals, we were always, I think, medical students were always at the front lines. And then we had the Sudanese revolution, and I was actually here in the US doing my doctoral degree, so I wasn't there for the revolution. But I think I took two lessons. At the moment of the revolution, all the times we went out, we got arrested or we got chased by the police. I think those made a lot of sense to me at that moment of following the revolution, because I realized even though they felt futile at the time, sometimes you will go on the streets and a lot of people on the street will tell you, you're a young child, just go back home, why are you doing this? And you feel like, who am I doing this for? But then I realized all of the knowledge people had over the years on how to organize, on how to protest, came to fruition when the revolution happened. So we were just building something. So that was really helpful for me to see that, yes, sometimes it takes small steps, but over time, those steps actually can lead to something big, something transforming. But I think a few years later, after the revolution, I'm left with thinking, I am not sure what is the right way to transform not just a country, a system. I think the revolution was helpful, but sometimes changing a system completely might lead to a lot of unintended negative consequences. And we're seeing this in Sudan right now. And it just made me reflect on what is the best way to actually improve a system that would help people. And sometimes you might be a privilege to say, just tear the system down, because I was sitting here in the US thinking it's easy enough to do, and then we improve the health of people sort of thinking about the reality of the daily life of millions of people who are actually living in Sudan right now. So those are just two contradictory thoughts, if possible, that are sitting in my head right now.
No, I really appreciate you sharing those. I mean, they really chime with me. Just growing up in Northern Ireland, for example, and experiencing a time of conflict, and then a time when there wasn't conflict, and experiencing how different the same events can be experienced by people based on exactly the forces that you're studying and interested in, and how it's very easy to argue for radical changes or to take extreme positions when you're more insulated from the consequences of those decisions and positions. And I'm always struck by the fact that, for example, thinking of tying together what you've said just now about the example of the revolution in Sudan, and also the focus we talked about before on often the biomedical, the tangible, the measurable. I remember in Northern Ireland during the conflict, there was a set of surgeons who became very famous in Belfast for doing reconstructive knee surgery, because they were very used to encountering knee injuries from punishment shootings. So it was a common punishment by paramilitary groups during the conflict in the sort of 70s and 80s in Northern Ireland, where they would shoot people through the kneecap. And often the people who would do this would then drop the victim off at the hospital. They would maybe surprise them at their house, do this, and then drop them off at the hospital. And so the doctors became very good. The surgeons became very good at reconstructive knee surgery and won awards, published great papers, kind of went around the world, furthering the knowledge of this procedure, which was lauded as a great thing and a positive thing. And it certainly was, it was a good thing objectively, tangibly, measurably. It was a good thing. But first of all, the people who tended to become doctors came from very different families and backgrounds to the people who tended to become victims. And even the very best surgery ended with the person being sent back to the community in which they were harmed, sometimes even to the same living room. And it is a really powerful reflection on both thinking through the reality of people's lived circumstances and the need to include a wider range of perspectives and data on those experiences, and the danger of becoming prisoners of the proximate, right? Of becoming prisoners of the most measurable and elevating that kind of medical savior, medical miracle above all. Does that make sense, or did I just go on a long tangent?
I love that phrase. What was it? The danger of the proximate, or what was it?
Prisoners of the proximate. Yeah, it's from an epi paper quite a few years ago. But it really struck me, right? Like that we become prisoners of the proximate.
Yeah. No, is that the Ross paper?
I can't remember now. I'll have to check. I'll definitely. Yes. I will check, and I will put it in the show notes for listeners as well.
I think that's a great way to phrase this, because I do think we're all, even the system, even the donors, they are prisoners of the proximate, and I really like the story that you told right now, because I think it's a great illustration of how, even if you want to help, sometimes the way that you're helping, even though it seems to you that this is the best way to address an issue, because of your position, because of your background, it is not necessarily or even close to being the best way to create a solution on a population level. I really like that story that you just told. And I think just to be clear here, I am not saying that people should over time, and I think we always need young people who have truly transformative ideas. I am not saying that should not be the case. I hope that I will forever hold my values and my passion about really creating a world where we address health inequities, not by addressing the healthcare system, but by creating a society where we don't have income as much of an income inequality as we see right now. We're a society where no one has to suffer to get housing, to get food, to get education. That's something, a goal I will always work for. I think we just, in a way, we have to be capable of holding two things in our minds. That yes, we have aspirational goals that we need to reach, but we also have the realities of the world that we need to work through. And sometimes we have to acknowledge that as we're going through thinking about our aspirational goals, people have to live their daily lives, and sometimes just giving them something that is helpful for the day or week or the year would be more helpful for them than our goal that could be reached in 50 to 100 years. So we also need to care about the daily needs of the people that we want to improve their health.
Yeah, actually, and it's fascinating because as we're talking, I'm seeing kind of a red thread that I presume has always been there in your mind through a lot of the scholarship that you've been doing, about imbalances in power, about the wider forces that shape health and how much they matter, about finding ways to bear witness to that through wider data sets, through a broader range of perspectives, involving a more diverse set of voices in these kind of conversations, and having a posture of learning, acknowledging that there is uncertainty and trade-offs, but there are powerful values that kind of drive us to think about the uncertainties and the trade-offs and to act in the best ways we can. I mean, even just thinking about I did want to ask you about one or two other papers, if that's okay, Salma, because I actually think in their own way, each of them really struck me in ways that papers rarely do. And one was a paper that you did with some colleagues on cardiovascular outcomes in the US over time. And this is something I use in my teaching quite often, especially with people from medical backgrounds, with medical students. And it creates almost a gasp in the room every time I mention it. And I think the paper I'm talking about. I was just wondering if you could explain the rationale behind that paper and what you think it says about sometimes how we are prisoners of the proximate, or we fail to see the impact that things like income inequality or resources can really have on health.
Oh, sure. And I'm really glad that it's actually resonating with some students. Sometimes you wonder if you write a paper that's just, it's out there in the world and hopefully someone in 10 years might just read it or get one copy of that paper downloaded would be great. So that paper, I think, so I came to the US and as I said, my conviction is that global health is about health inequities everywhere. So to me, it was part of my thinking was if I'm in the US and if I'm talking about inequities in Sudan, I also need to talk about inequities in the US. I need to think about inequities in the United States. And saw a figure once that was presented by Sandro Galea that looked into the income disparities in the US and how over a number of decades, the wealth of the top 20% of the population, so people who make, let's say in today's term would be about, a household would be about more than $110,000 or compared to everyone else in the US, the income of that group has been, and the wealth of that group has been increasing substantially over the past few decades, while the wealth of the rest of the US population has been staying the same. So in a lot of papers you look at, they look at people who are the top 20% and people who are the bottom 20%. What I wanted to look at is whether it's not about people who are way at the top and way at the bottom, but is it really about a select group of people who are at the top compared to everyone else in the US, especially given those disparities? So what we did was took data on the cardiovascular diseases in the United States for 2 decades and divided the US population into 2 groups. So those top 20% group and then everyone else, and look into cardiovascular outcomes. And what we found was that, and why we selected cardiovascular outcomes, it's because it's the number one cause of mortality in the US, but it's also, over the past few years, we've seen a lot of research that came out about how those numbers are decreasing in general in the US population. So we wanted to see what's happening there. And it was really interesting to see that while what we're seeing in cardiovascular outcomes overall is decreasing, that decrease is mostly coming from reductions among the top 20%. Wow. While outcomes for everyone else are either staying the same or increasing. So, and I think this is really where we need discussions about looking at the population in general and looking at overall numbers, but also looking into inequities within the population. Because if you look at the numbers in general in the US, you will say, great, the US is doing perfectly well when it comes to cardiovascular disease. It's reducing the mortality and morbidity in outcomes. But then when you look at the data, you'll see that no, that's actually happening because people who are rich are just getting better, while everyone else is either staying the same or having worse outcomes. And that's something that decision makers need to take a deep look into.
Yeah, no, you said it beautifully. I completely agree. You know, it reminds me of an editorial that came out during the COVID-19 pandemic by the New England Journal of Medicine. And I think the title was something along the lines of dying in a leadership vacuum. And it was this kind of historic editorial, you know, from the editorial board where they were critical of the US leadership during the first period. I can't remember if it was the first few months of the year of the pandemic, and, you know, challenges in getting tests out to people, in social distancing, clarity of messaging, etc. And I remember reading some commentary about this where they were saying, wow, this is really pivotal. You know, it's very rare for the editorial board to come out and say that that Americans are dying in a leadership vacuum. You know, this is really striking for a journal that often focuses on healthcare, right, on the proximate. And as you're talking there now, I was mindful of the fact that, gosh, that all those gaps in cardiovascular disease outcomes and deaths, right, all the gaps in attainment between the wealthiest 20% of Americans and the poorest 80%, which kind of seems sort of crazy to even say, the poorest 80%. Those are also deaths in a leadership vacuum, right? Like, those are a consequence of decisions that could be improved dramatically if they focus more on the social determinants of health. Is that fair?
It is really fair, and I think some critique and some thinking around this is always looking into the top 1%, and it's true, like the inequities there, it's just too high not to see. But I do think why we wanted to focus on the top 20%, not just the 1%, is because of who's making the decision. Yes, there is a 1%, there are billionaires that have a lot of money that we need to tax them. We need to figure out a way to redistribute the wealth and income in the country. But it's really about the top 20% who live in a world where they're making the decisions on behalf of the entire country. Those are the people who are making the decisions about transportation sector, about food security issues, about who to provide support to in the population. It is not the 1%. Yes, the 1% have most of the wealth, but it's that top 20% who are really making the decisions in the country. Not to get too political, especially about a country that is not mine, but it's that top 20% that really dominates Congress in the US, that dominates the executive branch. But in reality, that dominates also the judicial system. I don't know if you know, but the 9 justices in the Supreme Court all come from a few Ivy League universities. None of them really had to experience going to other universities. I'm not making a judgment about their own personal backgrounds, but it just shows that the decision making is in the hands of the few, and that's the few that keeps seeing their health getting better. So if we're seeing our health getting better, we're probably thinking everyone else is doing well. Why do we need to think about other alternatives to the policy or the decision making processes we have right now?
No, I think that's absolutely right. And again, that the importance of diversity of perspectives includes that too. I mean, it would be awful to think that you had diversity in terms of all the different states of the US or all the different regions of the world, but that they all attended the same university, or they were all the children of doctors and lawyers, you know, that would be diverse in many ways, but in other ways, like we're talking about, you're missing the perspective of perhaps the bottom 80% of populations, right? Like of the vast majority of people.
Just speaking of perspectives, very quickly, it's short. It's most a short story here because it's just reminded me like early during COVID, and it reminded me of like how my situation changed. I kept calling my mom on a daily basis, saying, "You need to be hyper vigilant when it comes to COVID. You need to do this and this and this." Like I called her multiple times. Ultimately, one day she had to. I think she had enough, so she told me, "Selma, whatever this is you're talking about, that's fine. Your cousin just had to stay in line from I think about like 5 a.m. to about 1 p.m. to get bread for the family because we don't have bread in the city right now. And bread is becoming too expensive. So even if she gets it, she's only get like maybe 2 or 3 pieces of bread for the entire family that day. So we're dealing with this right now. But thank you very much for talking to me about this. I'll take that into consideration. And I know my mom's just trying to. So it's really interesting to think about how our perspectives and how our positions really make us think. What we're thinking about, what we care about is what everyone else is thinking and caring about. And it's always good to reflect on that and maybe find a way not to have one perspective on everything in the room.
Yeah, absolutely. Oh, Salma, this has been a fantastic conversation. I've really enjoyed it, and I just want to thank you for such honest reflections. And they make me even more excited about what you're going to do next. Like, congratulations on your new position, and yeah, I'm so thrilled to think about how the scholarship will evolve over time and what new gaps you'll identify, what new perspectives that have been missed or marginalized that will be elevated by this kind of research. So thank you for all you're doing. I just wanted to end with, I always like to end with a question that's more geared towards early career folks, whatever the field they're in, advocacy, research, anything like that. You know, and as someone like you who has been involved quite early on with a range of initiatives, right? You've been involved with activism on the global health stage, but also with local initiatives. In Sudan, you've consulted for the Sudanese Health Ministry and these kind of things. And you've done a lot in academia as well and in teaching. What advice do you have about the balance, about the balance of all these different things? Because you've spoken very eloquently about how you still feel, more driven than you ever were, more practically minded than you ever were. But there is always a tension, isn't there, between doing things that are closer maybe to one's heart in terms of advocacy or in terms of the populations one feels a kinship and affinity to, and doing things that maybe have the maximum utility. And even finding ways to do things in ways that you don't suffer burnout. You know what I mean? That you can maintain course. Do you have any advice for early career researchers on how best to do that?
I am not sure I'm the best person to provide advice on this. What would I say? I don't know if this is helpful. I wanted to do clinical medicine because I wanted to help people in my neighborhood. And then I was frustrated and dissatisfied with what I can do. And then I decided I wanted to do policy and engage with the Minister of Health in Sudan and medical students globally, and then the WHO and the UN. And I was really frustrated and thought, oh, this is not really going anywhere. That's very helpful. I need to see immediate results. And then I decided, okay, let's try out this academia thing. It seems like that might be a place when you provide the data, things will definitely change. And I have to say, and you know this from our conversations, on a daily basis, you'll probably get really frustrated thinking, I provided the data on this, why are things not changing? So I think my recommendation to an early career person would be, change is hard. Change takes time. It's almost impossible, and I think I will be very happy for people who found something they do that fulfills their both their aspirations and their values. But I think in this field, it is very difficult to find one position that fulfills everything. You just have to figure out A, what are your talents, and B, where would you provide the most help most of the time while not feeling burnt out. And then sometimes do things on the side that would help move the needle, hopefully, on other issues. But I do think it is very difficult to find one place where you can make 100% difference, and just have to make sure that you're being driven by your values, and then know that change will take time. It's never going to be easy. You're going to be frustrated, but then keeping that in mind might be helpful. I would say then maybe doing things on the side would be helpful. So speaking to a friend of mine today on a podcast and going down memory lane is a good way to think about why I got into this. So sometimes doing things that are not necessarily in your job description would be helpful. And the last thing I would say, and this might be contrary to a lot of the advice people get right now, I think early career is a time to say yes to almost everything, to figure out what exactly fits at least the best as possible with your passion and your skills. So say yes to as many things as possible, and then until you figure out what you want to do, and then you can focus on that. But I think, yeah. And maybe don't listen to a lot of advice from other people who probably did things very differently, and there is no manual to how you do things the right way. But yeah, that's it.
I love that, Salma. Thank you so much. Thank you so much. I love that. I'm sure we will get comments saying, say yes to everything. What? How dare you? But I think there is real value in examining every opportunity and in really thinking, is this something new that will be closer to my values, that will help me figure out the longer term path for the maximum amount of good that I can do.
I agree, and not to double down just on the last words here, but I would say, honestly, early on, not just examine, say yes to everything. As you get more established in your career, it would be difficult to say yes to more things. And there were things that I said yes to that I never thought I would enjoy, including actually doing research. So you would never know. Say yes at the beginning, as long as you have the time and the opportunity right now, and acknowledging that for a lot of people, saying yes or getting options is not really a luxury they have. But if you have that luxury, take advantage of that. And then as you get more established, maybe examining the opportunities to know where your expertise would be more helpful is a good thing.
Wow. Thank you, Salma, so much for joining us on the podcast today.
Thank you, Nathan. This has been great.
Well, that's it for another week of Money Power Health. I hope you enjoyed listening to this podcast. I certainly enjoyed the conversation with Dr. Salma Abdalla, and I'll leave links to some of the issues we discussed in the show notes if you want to read further. I hope you have a wonderful week ahead, and look forward to sharing more podcasts with you in the future. And I will leave Charlie to play us out. Take care, and all the best.
If you enjoyed this podcast, please consider leaving a rating. It helps other people find it. The music in this podcast was by Daniel Manny. You can find more information about his music in the show notes. This announcement was read by the very talented Charlie Manny.